Hello, my name is Ed Rogan, and I'm going to be presenting my patient Rodney Cross. Rodney Cross is a 57-year-old Caucasian man who presented to the emergency department because of pain in his right leg. He states that he woke with the pain about 3 days ago and it has been continuous, although it does hurt more when he walks. The pain is located behind his right knee and extends down into his calf. He rates the pain intensity as 3 out of 10 at this time. He reports recent travel on a 14-hour flight to London, and he also states that he hates needles and would like to take something oral if possible. Past medical history: hypertension and hip surgery 1 month ago. He has allergies to sulfa, which causes hives. Social history is occasional alcohol use. Family history is non-contributory. Medications: lisinopril 10 milligrams PO once daily. Review of systems: cardiovascular, no chest pain, palpitations or syncope. Respiratory: no cough, shortness of breath, wheezing or stridor. Musculoskeletal: pain rated by patient as 3 out of 10 in the right knee and lower extremity. All others otherwise unremarkable. Physical exam: general, somewhat overweight, Caucasian man, appearing comfortable. Vital signs: 150/80 for blood pressure, pulse of 75 and regular, respiratory rate of 16, temperature of 98.3 degrees Fahrenheit, O2 sats 97% on room air, weight of 194 pounds, and height 6 feet. Lungs and thorax: breath sounds are normal with no respiratory distress. Cardiovascular: regular rate and rhythm, no rubs, murmurs, or gallops. Musculoskeletal and extremities: in the lower extremities, right calf is tight, warm to touch, and tender with 1+ pretibial pitting edema. Left lower extremities are without redness, warmth, and swelling. Normal range of motion. His pertinent labs are hemoglobin 11.5, hematocrit 34.7, platelets 186, white blood cells 6, D-dimer of 2975, BUN of 35, and serum creatinine of 0.8. All other labs are otherwise unremarkable. For his ECG, his sinus tachycardia, but has no T-wave or ST changes present. Venous Doppler ultrasound of the lower right extremity shows a deep venous thrombosis from the right popliteal vein to the right common femoral vein. Chest X-ray shows no evidence of acute pneumonia. Problem number 1, deep vein thrombosis. The patient is a 57-year-old male who presents with signs and symptoms consistent with a DVT, or deep vein thrombosis. He's a candidate for outpatient therapy with oral anticoagulation based on his ambulatory status, such as normal vital signs and lack of any renal dysfunction. His creatinine clearance is approximately 100 mL per minute, which is normal. Available therapies include warfarin, direct-acting oral anticoagulants, and fondaparinux enoxaparin. It can be bridged with either warfarin, dabigatran, or edoxaban. However, since this patient would prefer to avoid needles, we're going to go with the oral options such as rivaroxaban or apixaban. So, according to antithrombotic therapy for VTE guidelines, this patient's a candidate for 3 months of anticoagulant therapy. The plan we've selected for Rodney is rivaroxaban 15 milligrams taken twice daily with food for the first 21 days. Then change him to 20 milligrams once daily with food starting on day 22 there on out. For his patient education, we should start him on early ambulation and then also ensure adequate food intake. So we'll make sure to counsel the patient to make sure that he takes one 15 milligram tablet with food twice daily for 21 days and then switch to the 20 milligram tablet once daily after that with food also. Also, we're going to make sure the patient is going to monitor for any bleeding, including any black tarry stools. So to follow up and our clinical monitoring is we're going to be monitoring the patient for any signs and symptoms of bleeding, any signs and symptoms of DVT such as leg pain, inflammation, or redness, or any signs or symptoms of pulmonary embolism which would present as shortness of breath, cough, or hemoptysis. His second problem, hypertension. The blood pressure is not under control as noted by his blood pressure of about 150/90. He's currently taking lisinopril 10 milligrams PO daily, but it's a low dose, so per ACC/AHA guidelines, we're going to increase his blood pressure medication and try to get him to the goal of 140/90. So our plan will be to increase the lisinopril to 20 milligrams daily. For patient education on his hypertension, we're going to educate him on his dose increase and counsel the patient to make sure he keeps his salt intake below 1.5 grams per day. He should check his blood pressure at home every day and regularly, and also recommend regular exercise as tolerated for at least 30 minutes a day and follow that low-salt DASH diet. The patient is to follow up with his PCP in 2 weeks to reevaluate his response to the new therapy. So that was an example of a patient care presentation of an ambulatory patient. If this was a hospitalized patient, you'd want to mention the day of admission. For example, you would say today is day 3 of admission. You want to mention the chief complaint, but then go right into the overnight events or events that occurred over the last 24 hours. You'd want to emphasize daily labs plus any trends that are happening, and then the monitoring plans will be daily or even more often. Patient education is not necessary unless the patient is currently being discharged.